Very good afternoon, everyone. My topic is intended for the beginners, those who have started but having some difficulties during implant placement, especially BCS, and for those who want to start. So I'm going to share about the surgical techniques of placing, drilling of implant, especially BCS, because BCS is our gold standard. So I'm going to describe in a very simplified manner in mandible and maxilla. See, our brain is used to and gets accommodate when we do some action repeatedly. So we get mastery over this technique by maximum or consistent repetition. But as a beginner, we have to start. We have to take first step. So to take that first step, we should be confident that what we are doing and what we want to achieve. So I am going to simplify the technique prescribed by the none other than our Dr. Stephanie Dessers. Now, as a beginner, how to start strategic implantology? See, there are multiple criteria we have to follow. That includes the patient selection, that has to be clinical situation available, and the technical points that we should know and aware that what we are doing. In patient selection, initially we should have courage enough to say no to with high expectation patients. In India, we have conditions like oral submucous fibrosis, that is a restricted mouth opening. In that case, we struggle a lot to engage an implant in distal mandible or distal maxilla. So it's not easy initially. Yeah, after mastery, we can do it, but initially, we should not select such patients. Then we have to be extra cautious in patients with parafunctional habit as a beginner. And I urge you don't treat overseas patients who are not there for at least 3 weeks with you. In those cases, if you want to do, you ask patients to stay available for at least 3 weeks for follow-ups, and then you can do. And especially in segments or quadrant, you should be more careful that you should ask to come regular follow-ups, because segments, as a beginner, it's difficult to manage. So in segments, we should be extra careful. And initially, we should leave the mindset of that conventional implantology that we should search for patients who have the high bone quality or higher amount of bone quantity. Here, the scenario is different. In strategic implantology, as a beginner, look for the patients who have the less amount of bone, where there is no cancellous bone or alveolar bone is present. So you can directly land up into the cortical bone, and you can have initial anchorage easily. Then the lengthy or long alveolar or cancellous bone, where you require to place a longer BCS implants, which sometimes, because of not practice and not used to with the tactile sensation, it goes on wobbling inside the osteotomy, and we can leave the osteotomy and engage somewhere else, which can create trouble for us later on. See, we are osteo fixating first. So anyway, try to look for the patients with the less bone quantity, where you can easily drill and perforate and engage with the shorter length of BCS implant. So we should be careful by selecting patient also. In radiological, we should always look for the, see, we are not going for CBCT. We always look for the OPGs, and in OPG, what we are looking is white lines. Whenever you have OPG, try to see and search the white line present in the OPG. That can be the nasal floor, sinus floor here, or the junction of pterygoid on maxilla. You can also have the white lines of the internal or the external oblique ridge. These are the highly mineralized cortical bone. You should look for that, and these are the target area for us to engage with the BCS screw. We should also look for one more thing in the OPG initially, that is the condylar head, the shape and position of condylar head, because in parafunctional habit or patient with unilateral chewing, there will be changes in the condyle. Like this, when there is on the chewing side, there will be a higher remodeling over the condylar head than the comparing to the non-chewing side. So we should be careful, because in full arches, we don't want patients to be unilateral chewer post-operatively. So we should be extra cautious, and we should take measures to prevent post-operative unilateral chewing, because we need a bilateral balance function, that too according to the supporting polygon. All the contacts and the number of teeth should be within the supporting polygon. Rule out any bony pathology inside that can be easily appreciable on the OPG. There may be root stump present or minor small pathology, odontome or anything, cyst, anything can be there. So as a beginner, we should look for them, and we should rule out before operating. CBCT is helpful in a highly atrophied mandible to locate the position of inferior alveolar nerve, because in that case, sometimes we are generally, most of the time, we try to engage lingual cortical, but in those cases, highly atrophied cases where we cannot engage the lingual cortical, the CBCT may help us to find the location of inferior alveolar nerve, and we can engage on the vestibular side or the inferior border of mandible, like this. So CBCT may be helpful in such cases. Now coming on to technical guidelines, that all procedures we perform under local infiltration, because we are going blindly. We have methods, but we are going blindly. So if we may encounter nerve during osteotomy or during insertion, we can come to know, because patient will give us response. So that block should be avoided. All the procedure in the distal mandible or the anterior mandible has to be under local anesthesia. We should use artican instead of lignocaine, because artican has a better depth of penetration than the lignocaine. Because in lignocaine, what happens when we drill and approaches the second cortical and perforate in the maxilla or mandible, patients experiences pain. If we use artican, that will be better, because it has a more bone penetration, and it can anesthetize that deeper area also. All procedure has to be flapless, unless if you want to do a buccal bypass in the lower mandible, or if want to do a pterygoid implants by flap approach, then and then only all flaps should be open. Otherwise, all has to be flapless. Now the drilling direction and orientation, that is different for the anterior mandible and posterior mandible. In maxilla, it is also different in anterior maxilla and posterior maxilla. This is the physio dispenser showing the speed. Routinely, in lower jaw, we are using contra-angle handpiece, that is 20:1. The speed is we keep it highest, that is 2000, and torque we can keep up to 14 newtons. In maxilla, we are using 1:1 straight handpiece. We can use contra-angle, but in posterior or distal maxilla, it is a little bit difficult to drill with the contra-angle handpiece, because it requires excessive mouth opening and all excess. So straight handpiece is better in maxilla. The speed will be 20,000 minimum. We can go up to 40,000 also. These are the handpieces we use. Straight handpieces for the maxilla, either external or internal irrigation. And lower, we are generally using contra-angle handpiece, that is 20:1 gear ratio. Nowadays, the advantage for beginner is the availability of 3D printed models. So whenever you have a case, you are sending patients for CBCT, you can always ask for the 3D models where you can do practice. You should have 2 or 3 loose implants to practice beforehand, before attempting up into the patient's mouth. So these models are excellent, and they give most of the time cortical as well as cancellous feeling. So that if you practice it 2 or 3 times before doing actual procedure into patient's mouth, that will be a great help. Now coming to the preparation of site of the implant in the distal mandible. See, there may be two situations, either dentate situation or edentulous situation. If we have a dentate situation, see, always, first of all, always try to locate the mylohyoid ridge. That will be the prominent part on the lingual side of mandible. Below it, there will be a submandibular fossa. So always try to feel with the finger, which may not be that much discernible in the OPG or CBCT, but it is clinically, it is always there. So try to locate the mylohyoid ridge, and below it there will be a submandibular fossa. So if there is a dentate situation, we can easily go from the socket. We generally go in the distal root of the 6 and the mesial root of the 7. That will be in the dentate situation. Whereas in the edentulous also, we are preferring the distal root of the 6 and the mesial root of the 7. See, we say perforate the lingual cortical, but where? So this is the target area for perforation of lingual cortical. This is the mylohyoid ridge, and below it, this will be our target area where we need to perforate the actual lingual cortical. And during drilling, we should keep our finger in the submandibular fossa, so that initially we can feel heat. When our drill reaches the cortical, initially we'll feel the heat, then vibration, and then perforation. Many beginners have fear that what will happen to if this drill perforate the nasal floor or the mucosa. See, it is very below. When we are into the sublingual fossa, it is very below. And when we perforate, as I said, we first feel heat, then vibration, and then perforation. So as soon as we get the dip, we have to take it out the drill. And it doesn't irritate the patients. Many have fear that it will irritate patients if the implant is inside the floor of the mouth. It is well below the floor. Patient cannot feel it with the tongue. It can be felt only by the fingers, either by us or by patient himself. Now many beginners